All right, it's 1 o'clock, so I'm going to go ahead and get started. Thank you, everybody that's signed in or called in for attending. Really appreciate you taking the time out of your day to do this. My name is Marc DiSabella, and I'm a pediatric neurologist at Children's National Health Center. I'm the director of the headache program here. Please hold all of your questions until the end of this and just stay on mute until after the presentation, and I'm going to go ahead and get started. So today for the next half hour, we're going to talk about primary headache disorders. We're going to focus in on the classification, the pathophysiology, and basics of what we call the lifestyle modification of it. So again, I'm Marc DiSabella from Children's National. I run the headache program along with the child neurology training program here. I have no outside funding sources to claim. So over the next half hour, we're going to talk about the characteristics of the primary headache disorders, in addition to talking about the indications for different types of neuroimaging that you would order on patients that present with headache. We're then going to move on to the management of primary headache disorders, and finally talk about recommendations for referring to the headache program here at Children's National. So just to start off, headache is very common. This is the most common neurologic disorder in the entire world, and it's the most common reason people present to a pediatric neurologist. For example, tension-type headaches, which I don't have listed here, affect the vast majority of people throughout their lifespan. Migraine without aura is seen in about a quarter of the population, and it peaks between 15 and 25 years of age, so this is a big group of our patients. Chronic daily headache, which is people that have more than 15 headaches per month for more than 3 months, are seen in almost 5% of adolescents. Chronic migraine, so these terrible debilitating headaches for at least 15 days a month, occur in about 1% of adolescents. Then finally, medication overuse, which is people that use non-steroidal anti-inflammatories more than 15 days a month, or triptan medications like Amitriptyline more than 10 days in a month, occurs in about 2% of adolescents. So again, the point being that headache is extremely common in all of our practices. So before I think about anything else when I see a patient with headache, I think about, is it primary or secondary? So is it really because they have a headache disorder because nothing else is causing it? It's how their genes and the environment are working together to create migraine or tension or cluster headaches. Or is it a secondary headache? This is because there is a brain tumor, there's hydrocephalus, there's bleeding in the brain, they have meningitis, or simply they're overusing medicine. So the best way to determine that is to talk to the parent and the child about the temporal profile of their headaches. So when did they start, and what's been the frequency of them since they've begun? So on this slide, you can see the first and the third graph, the ones highlighted in this blue color, are the ones that are most concerning. This first one, which is somebody that has no history of headache and has an acute or sudden onset of a very severe headache, again, with no prior history of it, this is a really concerning graph here. This is consistent with somebody that has a hemorrhage in the brain due to a ruptured aneurysm. This could be somebody who had a slow-growing or fast-growing brain tumor and suddenly became obstructed and has obstructive hydrocephalus. Similarly, this third curve of a chronic progressive headache carries a differential of mass lesions in the brain. But this is somebody that started to develop headaches, and they're becoming increasing in their frequency and their severity. So they started off with a 1 out of 10 3 months ago, and then it moved up to a 2, a 3, a 4, a 5, and now it's every day all the time. That's what brain tumors do. That's what a lot of the more scary headaches that we're all worried about are. So again, the first thing I'm thinking about is that. These other three graphs are showing us the more common headaches that we see. This one, acute recurrent headache, is again somebody with no pain, and then all of a sudden they get a very bad headache up to a 9. That lasts for 24 hours and goes away, and they get another 9 out of headache 3 days or 5 days later. This is what migraine headache looks like. It's acute, recurrent, with periods of complete remission in between. If we move down to this chronic, non-progressive headache, this is somebody with a daily headache that's just the same all the time. This is what a chronic tension-type headache looks like, or another headache known as a new daily persistent headache. These are low or medium-level background headaches that never go away. This is actually a little bit of a sine wave. If you zoomed in on it, they have little ups and downs, but overall they just kind of have this background to them. And then finally, this mixed headache, the last one, is somebody that has a background headache with bigger headaches on top of it. And I see this in my clinic every week, and this is what happens in people that are medication overusing, so people that take Motrin very regularly. They have a background of a 4 out of 10, and then as they're off of their dose for a few hours, the headache, and during their withdrawal, the headache increases again, and they move back up to their 9. They take their Motrin, it goes back down. Motrin wears off, it goes back up, so they're in this period of up and down, which is what we see again with rebound headaches, also known as medication overuse headache. So in your initial evaluation in the community, you would think about some of the most common initial symptoms that people could present with. So tension headaches are typically described as being all over the head, they're not throbbing, and they're mild to moderate, and not really associated with other symptoms. In contrast to migraines, which are typically in the front of the head or on the side of it, these are moderate to severe. They tend to be pounding or throbbing. They make children want to lay down in the dark and quiet. They may even have nausea or vomiting with them. Migraine aura is neurologic symptoms associated with the migraines. And those can be things like vision phenomenon, sensory phenomena, or speech changes. And then finally, you want to think about other secondary causes of headaches, so things like sinus headaches, post-traumatic headaches, allergies this time of the year. Is it an eye problem and they have eye strain? Could it be depression manifesting as headache? So currently we use a set of criteria called the International Classification of Headache Disorders, and we're on the 3rd edition of that, and this is how we classify different headache disorders. So we're going to walk through some cases here and think about what types of headaches each of these are. So first off, the very common scenario, you have a 16-year-old female presenting to your office with headache. She's had them for quite a while now, let's say for 6 months. She describes them as being frontal, throbbing, 10 out of 10, and when she gets them, she lies down in a dark, quiet room. She notes some tingling on the left face, arm, and leg at the onset that lasts for about 10 minutes, and this occurs about twice per week. This is a very good example of somebody with a migraine with aura. So again, the migraine criteria are that you have 2 of the major criteria, which include the location being across the front or on one side, they're throbbing or pounding, they're moderate to severe, and they're worsened with activity or relieved with rest. And you need 1 of the minor criteria, which include nausea, vomiting, light sensitivity, or sound sensitivity. And the light and sound sensitivity can actually be implied by the child's behavior. So you can ask the parent or the child, when you lie down, do you prefer the room to be dark? Or just ask the parent, do they typically lie down in a room with the covers over their head, or the lights off, or noises off? And then, as I mentioned, this child who had tingling had an aura. So people have used a variety of different terminology for this in the past, but luckily in this 3rd edition of the headache classification, they've now put everything under aura. So there's no longer words like complicated migraine, and actually basilar type migraine has even gone away, which is in the middle of this, and now we just call a brainstem aura. The 3rd one, which is familial hemiplegic migraine, we also call a motor aura. So you can really simplify it and just call it aura all the time if there's a neurologic symptom, and then say what the aura is. So if it's visual, you can call that a migraine with visual aura. Sensory, obviously, is a sensory aura. And then speech, we typically try to classify what type of speech problem. The most common is dysphasic, meaning that they have dysarthria during it. It's much less likely to be a true expressive or receptive aphasia. By definition, auras develop rapidly over about 5 minutes and should typically be less than 60 minutes and then go completely away. During that time, we expect the headache to start as well. Again, basilar type migraine, which has been renamed brainstem aura, is just a migraine who has an aura that's associated with different brainstem symptoms. So remember, your brainstem has all the lower cranial nerves in it, and because of that, you could have symptoms from double vision to ringing in the ears to ataxia to altered consciousness, which people used to call acute confusional migraines. Again, now is really just brainstem aura. People could have bilateral paresthesias, visual phenomenon in both eyes. And similar to the other aura criteria, they develop over 5 minutes, go away within an hour. And then finally, there's hemiplegic migraines, which are the most severe type and thankfully the rarest. And these are people that look like they had a stroke. They develop one of the other more common auras, so visual, sensory, or speech, in addition to having a completely reversible motor symptom that looks identical to stroke. So these kids definitely freak us all out a little bit because we're worried they had a stroke on the front end, and over time they may declare themselves as being hemiplegic, and then we don't have to do MRIs every time or things like that. But on the front end, I'm doing a workup as if this is stroke every time for a little while. So I think about migraine as being a bunch of overlapping disorders. So migraine's kind of the big category, but really it's a dysautonomia. So there's migraine without aura, which is the most common one. That's going to be about 70% of kids with migraine. You have migraine with aura, which is about 30% of them, and as we mentioned, visual, sensory, speech, motor, brainstem are all parts of that. Then there's the vasomotor disorders, so about 30% of patients with migraines have syncope or orthostatic intolerance, or the new trendier postural orthostatic tachycardia syndrome known as POTS. And then finally, before kids get their migraines in the young age, they may present with migraine precursors like abdominal migraine, which is essentially a migraine in the abdomen. They're described as typically being dull or periumbilical pain, may have associated nausea, vomiting, or a pallid appearance, or anorexia during the spells, cyclic vomiting syndrome, or benign paroxysmal vertigo. But again, all of these really fit into the same bubble, which is that they're dysautonomias. That's what I wanted to talk about a little bit, was the pathophysiology of migraine. So I use this model to explain this to patients so they understand how the real world or their environment impacts their headaches. So if you go to step one at the bottom here, what we're talking about is, first thing is there's a metabolic stressor. So that metabolic stressor could be that you skipped a meal, it could be that a weather front's coming in, it could be in females that their menstruation is coming on, or it can be emotional stress, a big test, a kid that bumped into you into the hallway, or just stress in general. But all of those things result in an overall energy deficient state in the brain. And when the brain becomes energy deficient, there's nuclei in the brainstem that get activated, and they actually start shutting down the cortex from the back to the front, which explains why visual auras tend to be first and most prominent, because the back of the brain is the occipital lobes, the vision cortex. Then moves anteriorly to the sensory cortex and the speech cortex, which again, in order of commonness, are the next most common auras. After that happens, the brain has a compensatory dilation of the blood vessels around the brain. And the blood vessels in the brain are coated with the trigeminal nerve, which is the only nerve we feel on the scalp in front of the head. So again, you have a metabolic stress resulting in neurons shutting down, resulting in compensatory vasodilation, which stretches out the trigeminal nerve and gives you a bad throbbing pain, typically in the first division of the trigeminal nerve, which is most prominent around the eyes and in the forehead. So moving on to our next headache type. So now we have a 15-year-old female who presents with headache that's in the frontal and occipital areas. It's described only as a 3 out of 10 on a pain scale, and it's not worsened with activity, and the quality is more dull and non-pulsating. This is a good example of a tension type of headache. So tension headaches typically last between 30 minutes and can last up to 7 days, and they have 2 major criteria, typically bilateral, non-pulsating, mild to moderate, and not worsened with activity. And then most patients will not have light or sound sensitivity, but they can have one of those because, as most of us know, when we have a headache, the last thing we want is loud noises. And there is no nausea or vomiting associated with a tension headache. Again, this is the most common headache in the entire population, and everybody on this call has probably experienced a tension-type headache at some point in their life. So this leads us, so we've gone through now, is it primary or secondary headache? So we've thought about, is this something more serious? Is this brain tumor, aneurysm that ruptured, all those scary things? And based on the temporal relationship, we've got some clues there. We've asked some basic questions about pain quality, location, severity, relieving and exacerbating factors. And we're pretty much clued into the fact that we think it's either a primary or a secondary headache. And now the next question is, who needs an MRI or a CAT scan? So the best data on this comes from a study in the Journal of Radiology in 1997, and what they were looking at was the MRI findings in a number of children, about 300 children between 3 and 20 years of age who had headaches. And 28% of those children had one abnormality on their neurologic exam. It could be anything from papilledema to a 6th nerve palsy to weakness or ataxia to tingling. Of those patients that were studied here, only 4% actually had a surgical space-occupying lesion, meaning something more serious was going on. And every one of those 13 children had abnormal exams. So that's very reassuring in my office, and I bring this data up quite often. If you feel confident in your neurologic exam and it's completely normal, the likelihood that child is going to have something structural in their brain is very low. I can say from my experience, which is almost 10 years at Children's, and we see about 2,500 children with headaches per year. Everybody with a space-occupying lesion I've discovered has had an abnormal neurologic exam. I have yet to have been surprised, and I order lots more MRIs than are probably indicated. So what this study showed was that there were 6 major factors that determined who needed those. Again, the abnormal exam is kind of the big one, but in addition to that, somebody who has a new onset headache that's not responding to basic management, headaches associated with anything abnormal on the exam, but papilledema, nystagmus, gait, and motor changes were the most common. There was a statistical significance to an absent family history of headache. Notice that doesn't say absent family history of migraine, so you have to be very open about this. So I usually say to families, who in the family gets headaches of any type? This includes sinus, tension, menstrual, stress. But you want to put out a big net on this one because otherwise they might not consider their migraines to be migrainous, in fact. Any headache associated with substantial confusion or emesis, headaches that repeatedly awaken a child from sleep. So this is not a child that woke up with a headache. This is a child that the headache woke up between 4 and 6 in the morning most often, and that's because they're obstructing overnight and they actually have a brain tumor causing obstructive hydrocephalus. And finally, a family history of a brain tumor or multiple cerebral aneurysms. A single cerebral aneurysm was not significant because about 4% of the population has those and they're very unlikely to rupture, but anyone with multiple cerebral aneurysms is associated with a genetic risk because of conditions like polycystic kidney disease. So in regards to when to consider a consult and referral to us, so if you have a patient who has a recurrent headache and a normal neurologic exam, they typically are not going to require additional testing. Again, we talked about the different reasons for brain imaging, and then you want to think about specific testing for children with other systemic complaints. So if I have a child with an arthralgia and a rash and a low-grade fever, I'm now in the Lyme world. But without those symptoms, I'm not typically thinking about those things. Same with the child with a lot of sleep complaints and snoring, I might be thinking about obstructive sleep apnea. So again, think about your review of systems and other systemic signs that they may have. So what's the basic treatment that should be given for everybody with primary headaches? So there's 3 major arms to migraine treatment. We always provide behavioral strategies, which we also call lifestyle modification. Those are known to be the best thing to try and prevent these. Everyone should be offered some form of acute abortive or rescue medication, and a small group of children may require daily preventative medication. So I typically use this approach to try to explain migraine and a treatment plan to a patient and family. First, I talk about the specific criteria for migraine. In fact, they're on the back of the handout I use, and I check off the symptoms the child has to show them which symptoms the child has and why this is migraine. I then have that diagram I showed earlier with the brain and the arrows moving around it to discuss how their lifestyle and their environment can in fact trigger headaches. So when they're dehydrated, when they're skipping meals, when they're not sleeping well, how that's potentially going to activate this nerve, which is going to cause the head pain. And I have to say, even though this sounds very cerebral and academic, I think explaining this to families is extremely important, and more people thank me for that part than anything else I'm doing, because they just want to understand what's going on and they want to be reassured that this isn't something worse. And by telling them this explanation, I really feel like they get that out of it. Next is you want to talk about a treatment strategy for the patient's migraine. We really focus way in on lifestyle modification and each of the pieces of that. It's not just saying sleep more, drink more, and eat more. I give them a very specific guideline, and I'm going to show you my handout in a minute. We talk about some behavioral strategies as well. We talk about abortive medicines and then preventative therapies if needed. And again, a standardized handout can really help with this. Next, I talk about diagnostic testing and whether people have the indications for this. So the study I just showed you is something I'm quoting, and I actually have that table that we used in the slide is right next to my desk on the wall, so every parent can see it because I'm not trying to hide anything from them, and I want them to know that those are the reasons we need to do MRIs, and people without them probably don't need them. I give everyone contact information for support in between headaches. As you know, headache patients require more support than some of our other patients, but this is really critical to their success. So you want to enable the families and the patients to take care of themselves as best as possible. There's still going to be situations that they don't know what to do in, and it's important to provide them with a setup kind of for success with that. I also give everybody an emergency department protocol in case they have a migraine lasting longer than 72 hours, so that they know what they can do if they're away on vacation or it's a weekend and they need to do something, they have the power in their hands, and then provide specific follow-up timing. So this is what my treatment plan looks like. We use this in our entire headache center, which we have 6 providers in. So on the top of it, you can see it has a lot of the different diagnoses we're going to use, and I circle off the ones they fulfill. And then the biggest part of this handout is all about prevention. And the bulk of that is lifestyle modification and the behavioral management. So the lifestyle modification includes a very specific fluid goal. Here I'm using 2 times maintenance fluid. So it's roughly their weight in pounds, and I cap it at about 100. So a 100-pound kid, I tell 100 ounces. Anything below that, I just use their weight in pounds or multiply their weight in kilos by 2. I educate everybody to avoid caffeine and artificial sweeteners. These have been shown to be the most common triggers in the environment. There's lots of other triggers that have been disproven, including chocolate. So I really don't focus in too much on those things because they're very unlikely to be the case. Next, we move on to aerobic exercise, and we talk about the fact that we recommend 5 days a week for 30 minutes of aerobic activity. When I explain that, I explain why. So I say when you do aerobic activity, it tones the blood vessels in your body, which is going to keep them tighter so they can't stretch out. It's also going to increase the efficiency of neurons so that they don't need to use as much oxygen. It's going to make red blood cells more efficient in carrying oxygen. So again, it goes back to that model we explained, but you need to sell this, otherwise they're not going to follow along. Same with the fluid goal. I explained that drinking more is going to increase blood volume, which gets more oxygen to the brain for more energy. And this is how I get, I think, kids and families to buy in. We talk about sleep recommendations, and here we use the American Academy of Pediatric recommendations. It's usually between 8 and 12 hours, depending on age. And then talk about sleep shifting. Children that have more than a 2-hour shift in bedtime or wake-up times have significant increases in headaches. So this is typically manifested as kids that sleep in on weekends and get early weekday headaches. Monday through Wednesday headaches are oftentimes circadian shift headaches. Talk about not skipping meals because relative hypoglycemia can trigger headaches by stretching blood vessels. I then move on to some behavioral strategies. So as we know, screens are becoming more and more used. So we talk about taking rest breaks with prolonged use, and actually my most updated handout says not to use screens within 2 hours of bedtime to prevent circadian rhythm shifts as well. We talk about participating and distracting despite the headaches. So this isn't saying tough it out, but it's saying that when you have a headache, sometimes the best thing you can do is not think about it. And I have kids go to the movies with their friends or play a game with their parents because being distracted can be very helpful. And in fact, that causes neuronal desensitization. Desensitization means that neurons start ignoring signals if you do as well, and it's really important. And then finally, this last one is something that parents oftentimes are kind of shriek or are taken back a little bit with, but it's very important to talk about not talking or asking about pain. A lot of these families check in with their kids about pain every day, and this really can exacerbate it. Any sensory symptom in the body is exacerbated by any sort of conscious radar looking for it. If you ask anybody on the phone right now, do you have a headache? The first thing you do is scan your body and think about it. We don't want our kids thinking about headaches more than they already are. Beyond this, we talk about any sort of medication that we're going to use as a preventative. I typically recommend riboflavin every day for kids based on a good randomized controlled placebo trial that showed that 200 milligrams daily of riboflavin was significantly effective in reducing headache frequency and severity if taken for 4 months. Next on, we move down to the acute treatment, which is again our rescue. This is educating people on what to do when the headache starts. So as soon as the headache starts, I have people drink a 12-ounce Gatorade or a Powerade, but sports drinks are great for this. They have a high content of electrolytes, which gets a big blood volume or oxygen burst up to the brain, and they have a bunch of sugar. And neurons love glucose much more than any other substrate in our body. So I always tell people about this. We recommend avoiding G2 and Propel because they have artificial sweeteners. And then I'm going to tag in some form of abortive medicine. We typically start with non-steroidal anti-inflammatories like ibuprofen at 10 milligrams per kilo or naproxen sodium at 15 milligrams per kilo. And anytime I'm telling them about that, I'm telling them how to avoid medication overuse headache. So non-steroidals can be used up to 15 times in a month, which is about 3 days in a week. So right on that line next to the medicine is the maximum use. If I'm prescribing a triptan like sumatriptan, rizatriptan, zolmitriptan, I give them the drug, the dose, and similarly I tell them the maximum use, which in this case would be 2 days in a week because we want to avoid more than 10 days in a month. You can see moving below that, says if your child has a headache longer than 3 days, go to an emergency department for the protocol, and the protocol is right on the back of the sheet, and then we finish up with what testing they need. So this is really what we just talked about. So again, when you see somebody with headache, talk about the basic first-line management, which is hydration, exercise, sleep, and diet. We talk about specific abortive therapies, starting with ibuprofen with its fluid bolus, and then consider triptans if the child has no contraindication. Again, preventative medicines might be used in children with very frequent headaches. Cyproheptadine and amitriptyline have been used for years, but as I'm going to talk about in a couple minutes, there's some new data suggesting that these may be less effective than we thought prior. So for those not familiar, CHAMP is the largest headache study ever, and it came out this year in the New England Journal of Medicine. We were lucky enough to be one of the sites enrolling patients in this study. So what it looked at was the 4 lifestyle modification techniques we talked about, so hydration, exercise, sleep, and diet, and it randomized children after 4 weeks of doing that to taking amitriptyline 1 milligram per kilogram, topiramate 2 milligrams per kilogram, or a placebo. And at the end of a 24-week trial, 350 children were enrolled, and there was no statistical difference between any of the 3 groups. So the placebo group did just as well as the drugs we've all been relying on for quite a while now in prevention of headache. It's not to say that these drugs don't work. There's a 70% response in these drug groups, meaning a reduction in headache frequency. But the placebo was just as good. So the biologic properties of the drug made no difference whether it was placebo or one of these anti-epileptic or tricyclic antidepressants. So this really was game-changing for headache practices and child neurologists, and it showed us that the focus really needs to be on healthy habits, lifestyle modification, and rescue medicines. And that's really where we are right now. As a follow-up to that, the same group that published that, which is an NIH-sponsored trial, published a trial back in 2013 in JAMA using cognitive behavioral therapy. So cognitive behavioral therapy is another means of treating headache and uses techniques like relaxation, in addition to biofeedback, to try to reduce headache as well, because when children initially start to feel headache in a stressful situation, they start amplifying it themselves and escalating it, thinking, oh no, here it comes, I'm not going to be able to stay in school, this is a terrible headache, as opposed to warming their hands, taking deep breaths, slowing heart rate, decreasing blood pressure, and decreasing brain metabolism. What this study did was have a group that was getting CBT plus amitriptyline and a group that was getting a fake form of CBT. They were just meeting with a therapist who just talked with them but didn't provide them with any of these skills and gave them amitriptyline. And at the end of the study, you can see the days with headache are reduced in the CBT plus amitriptyline group, and their disability score, known as PED-MIDAS, is also significantly decreased. Because we know from the CHAMP study that amitriptyline may in fact not be more effective than placebo, I really think this is going to show that CBT is going to be a mainstay of treatment. And in fact, we've seen that in our practices as well. So moving on to the referral guidelines, so some of the reasons to initiate a referral. So if you have a patient with a new onset severe headache that is acute with a focal neurologic exam, send them to the emergency department. That is an emergency, and this child needs a CAT scan or an MRI today. If you have a child who has recurrent headaches that's not responding to standard treatment, that's something you should definitely refer in to us. If you have a headache that's making children miss school or not having good participation in school, we want to see that as well in neurology or our headache clinics. And when they come to the visit, things like a headache calendar, medicines they've used, and any tests they've done are very helpful to us. So I want to talk a little bit about our headache program. So for about a year and a half now, we've had an urgent headache program, and there's between 50 and 80 slots per week available, and the slots can only be booked out about 5 days in advance. So if you have patients, call 202-476-HEAD or email headache@Children's National. You're going to get in touch with our headache coordinator, who can get people in within 1 week of calling almost all the time. Additionally, we have an interdisciplinary intractable headache clinic every week run by myself and another neurologist and 2 of our pain psychologists. And these are very long appointments where we provide patients with cognitive behavioral therapy, biofeedback, and really address every aspect of their life to try to improve their headaches. So this is definitely a resource available to everybody in the community. These are some of the people involved in it. So that's myself, Dr. DiSabella, Dr. Langdon is in it, Dr. McClintock, and Dr. Fletcher is the head of the behavioral pain medicine program as well. In addition to those specialists, we have other specialists that can provide additional treatments. So Dr. Alexander is one of our anesthesiologists who does occipital nerve blocks and trigger point injections. Dr. Oligbu is one of our neurointerventionalist neurosurgeons who does occipital nerve stimulators and other neurointerventional procedures. And Dr. Reese is also in pain medicine and provides acupuncture in our clinics. So this is a summary of all the different things we talked about. This will be available on the website online, but we've talked about each of these. So again, how to think about the headaches at first, how to provide basic management, who to do testing on, who to refer, and what to bring to that appointment. So again, you want to first classify the headaches based on standard pain questions. Remember, the trigeminal-vascular system is implicated in headaches. Talk to everybody about hydration, exercise, sleep, and diet. Give everybody a rescue plan. Cognitive behavioral therapy and lifestyle modification are likely the most effective treatments. And at this point, daily preventative medicines have some questionable efficacy. Finally, I just want to remind everybody that the Pediatric Neurology update is coming up on Wednesday, April 19th. This year, we're going to be focusing on movement disorders, and it should be a really fantastic conference. We're going to be talking about Tourette syndrome, other movement disorders, and there's some general topics as well. So if you'd like to register, just go to childrensnational.org, the neurology update. I want to thank everybody for attending. I'm sorry I went 1 minute over. I'm happy to answer any questions at this point if you take your phone off of mute. And thank you. Hit *6 to unmute if you're trying to talk on your end.
Hi, I have a quick question about SSRIs and rescue medications. Do you worry about triptans with SSRIs, serotonin syndrome?
Right. It's such a good question. It comes up every day in my practice. So SSRIs and triptans both do bind to serotonin receptors. Good news is they bind to different serotonin receptors. So triptans bind to serotonin 5-HT1B, 1D receptors, which is a different subclass than SSRIs. So to date, there's no pediatric case reports or reports at all of patients getting serotonin syndrome on a single SSRI plus a triptan. I worry much more when patients are on multiple SSRIs, have significant depression, things like that. But the patients I've seen get serotonin syndrome have been having alteration of their SSRIs, but not the triptans necessarily. So I've never had somebody take a triptan and get serotonin syndrome. It's somebody that's doing other things with their management. But I bring it up to every patient no matter what. If they have that combo, I explain what serotonin syndrome is, what it looks like, what to watch for when they go to the ER. So they all know that up front. But then I say, great news, this doesn't actually happen in real life just yet, but I don't want you to be the first person. If you are, here's what you got to do. So yeah, great question.
Okay, great, thank you.
Any other questions?
Hey, Mark?
Yes.
Mark?
Yes?
Hi, this is Clydette Powell. Very nice presentation.
Hi, thank you, Clydette.
Will the presentation be available as a PowerPoint on the website?
It will, yeah. Yeah, it'll be uploaded later on, and you'll be able to see everything there.
Great, fantastic. Good review, and I love to see how the headache treatment plan sheet is updated. That's great. More helpful.
Thank you, Clydette. Good to hear from you.
Likewise. See you on the 19th.
All right, great.
Bye-bye.
Bye-bye. If there's no other questions, if you do have any, please feel free to call 202-476-4323 for any referrals that you might have, and that's also the headache program line. Again, that's HEAD, or headache@childrensnational.org. You'll get me through that if you do have any questions after this. So thank you, everybody, again, for attending. Happy Doctor's Day, and have a good rest of your Thursday.
Thank you.